Our next presentation will be from Roger Zemp from the University of Alberta, who is presenting about how he and his team were able to release genetic biomarkers from cells using ultrasound. Sorry, I have to find the mouse. Can I have some tech support?
I think it's a dual screen display issue, so
Okay.
there we go.
Thank you. So you fix that here,
Yeah,
and then pull it up over there.
yeah. Okay. Hi, my name is Roger Zemp from the University of Alberta. I'll be talking about using ultrasound in a new way. So some of you may have had an ultrasound scan before where it's used for medical imaging purposes. That does not give information that would be valuable to doctors beyond structural imaging. So what we would like to do is provide a whole set of molecular information in a new way. So one of the ways we do this is to inject a new type of agent called nanodroplets into the bloodstream. These are similar to contrast agents that are already used by doctors, but they're smaller, so they can go and interact with cells outside of the blood vessels. Then when we apply ultrasound in a focused ultrasound that's much stronger than you would normally use in biomedical imaging, it interacts with the cells, pokes tiny little holes in them, and it creates little sacs of material that come off of the cells. These are called extracellular vesicles. And these are shed into the blood, and then they're simply sampled with a blood test. So as you do an ultrasound procedure and a blood test, within the blood test, you pick up on extra information contained in these vesicles. And these vesicles contain things like mRNA, DNA, proteins. And then we analyze these biomarkers to get information about, for example, cancers. So we found that this procedure can release about 100 to 1,000 times more biomarkers into the blood than are normally present. So a normal blood test doesn't give much information about a cancer, but now we have a way to detect these markers from the cancer due to a simple blood test. For example, we found panels of tumor-specific mutations that were otherwise undetectable. And this could, in some situations, be a potential replacement for a core needle biopsy. Our next version of this project uses another version of ultrasound technology called microhistotripsy. This involves turning up the power of the ultrasound to actually completely obliterate all the cells within a tiny, tiny volume. So previously, histotripsy was used to create cavitation damage in big volumes for therapeutic applications. The new technology gives pinpoint liquefaction of tissues down to 50 nanoliters, and it only occurs in that damage area. So this is an ultrasound scan where, just like you would have a normal ultrasound exam, but this little area here with a white color map, actually there's these tiny little microbubbles that are created just due to the huge peak negative pressures of ultrasound. So it's kind of like if you have a bottle of pop and you open it, you lower the pressure and the bubbles come out of the solution. And the same thing's happening, but we're using ultrasound to create that lowered pressure locally, and it creates those microbubbles, and it creates this damage that doesn't happen with any type of normal ultrasound scans, only with this very intense treatment. And then you release these biomarkers. And so what we do, we can either, again, take a blood sample, or in this case, we use a fine gauge needle to actually insert into the tumor. This is a video showing this procedure in action where, I don't know if you can see, there's like a bunch of action going on in that cavity where the ultrasound is destroying just that tiny little bit of tissue. And then we actually insert this fine gauge needle and suck up the liquefied tissue, and it provides much more reliable source of genetic information than is otherwise possible with a fine needle procedure. Otherwise, you'd have to use a large biopsy needle that has a lot of tissue damage. But the fine needle procedure can now get orders of magnitude more information than we were able to before. So for example, if one would want to know if a suspicious mass is a breast tumor or not, you might look for a genetic marker called an epimutation. This particular epimutation is called BRCA1. And so this graph here shows if you just only use a fine needle to sample, sometimes you get something, sometimes you don't. A lot of times you don't get anything. But with our procedure, you get orders of magnitude more information, tens of thousands of times more information that's always reliable, so you can do genetic testing. Another version of the project where we don't apply ultrasound to a patient at all. We only take blood samples and then apply the ultrasound treatment only to the blood sample. So with this, we take a blood sample, we centrifuge it and isolate a fraction of the blood and apply ultrasound to that using this special setup here. And then we use something called quantitative PCR to look for biomarkers that are present in circulating tumor cells that might be in the blood, but absent in the normal blood cells. So this is important because circulating tumor cells are the cells that are shed off of tumors, and they go through the body and they can create other tumors elsewhere in the body. So they're dangerous, and this is what causes most of the deaths due to cancer. But there might only be a few circulating tumor cells in a blood draw. So this is a 1 in a billion needle in a haystack problem. And so we use this procedure, and long story short, we're able to detect even a single circulating tumor cell in a blood sample and be able to collect these circulating tumor cells from the whole blood volume, detecting as few as 1. And we believe this is powerful. So the other ways of doing this is something called cell search, and it costs about $10,000 per test. And we think we can do it for about the price of a COVID test, for $10 to $100. So we also did some studies with prostate cancer patients where prostate cancer is heavily overdiagnosed, and the doctor really wants to know, is this something that could kill a man, or do we just watch and wait? And they have to make difficult decisions about whether to biopsy, and the patients hate the biopsies, etc. So long story short, we found that we could detect clinically significant prostate cancer much more reliably than the current standard of PSA testing. So we could detect a single circulating tumor cell, and these curves here show our detection performance. And long story short, we think that up to 30 to 50% of unnecessary biopsies could be avoided with future work and expanded clinical studies. So, and this could also be applied in other settings where earlier detection could save lives, and it could be used to track therapies, and breast cancer, melanoma, and other cancers are under investigation with this. So with that, I'll close and thank you for your attention.
Okay, thank you so much, Roger. At this time, we can take questions from the audience.
All right, so we have a question from Jessica Sensarin. She's wondering if you could recap the types of cancer that were examined for these tests and kind of just talk about which ones you identified or worked with.
Right, so for this first project, it was not yet in human subjects, but we looked at breast cancer models primarily, and hepatocellular carcinoma models. And for this project, we've looked at breast cancer models and melanoma models and prostate models. And then for this last project, we did use human subject blood samples, primarily from prostate cancer subjects, but we're also starting to look at recruiting patients for breast cancer and melanoma.
Thank you for clarifying that. We have a question from Richard Lovett. He's asking, is there risk or is there a risk of these methods creating circulating tumor cells that are knocked out of the tumor?
It's a good question. In one of our previous papers, we showed that that's not the case, that it does not increase any risk of metastases. And in fact, some papers have even shown that because you're disrupting cells and presenting the tumor cell antigens to the immune system, it actually heightens the immune system and actually has an improved anti-tumor effect even elsewhere in the body. So you could treat one part of the body and it will actually cure some of the tumors elsewhere in the body, especially if that's combined with therapies like immunotherapy.
A couple more questions here. Would this procedure be able to be done during an initial or a general ultrasound appointment for a cancer patient?
We hope that's the long-term objective. So, like for example, in breast cancer, a woman will usually have a mammogram first, and then if there's something suspicious, there would be a follow-up ultrasound scan to see, often things don't show up as so well on the mammogram, but it's good at evaluating the whole breast. So then the ultrasound scan is usually used as an adjunct modality, and sometimes there's a mass and they're unsure about what the mass is. It could be a fluid-filled cyst or it could be a benign mass. And so the way to find out is a biopsy. And so we think that some of these procedures could be a potential replacement for those biopsy procedures, so a big 9-gauge core needle biopsy is pretty big. It's a few millimeters in size, and this would be a lot less invasive and less painful.
Thank you. And I think this is our last question from the online audience. It is, are there other applications for this kind of sensitive biomarker test beyond cancer screening?
We hope so. So it could be used anywhere that getting biomarker information might be valuable. Studying even like heart tissues after a heart attack, or to assess if someone has a atherosclerotic plaque that might be vulnerable to rupture, to look at the profiles associated with also precancers, things that are not yet developed into cancer, but if, like in the esophagus, or something called Barrett's esophagus, it's precancer that they want to detect, right? So that would be important to detect things early. So yeah, a few things could be possible. Thanks.
That's very exciting. Thank you. And that's the end of the online questions, Maura.
Great, thanks.
Thank you to both our presenters today. I learned so much. And thank you to everyone joining us. Our next press conference will be held at 11, and after that, a 2 p.m. press conference. Thank you all so much.